before we start, we're sorry for this delay to start our proposal because we have this as projector problem. And before we start, we'd like to thank Dr. Garth Beache for accepting our invitation to be the first speaker in our BE Fall 2017 seminar series. I know Dr. Garth Beache since 2009. We started to collaborate in different research projects. We started with the heart, then we worked together in other projects like autism and the kidney. And today he will give us an overview about his heart project that he did at the Department of Radiology, and I think also with Dr. Bori. So again, I like to thank him, and I can mention in front of you, I enjoyed working with him since 2009. Before we start, Dr. Garth Beache, if you didn't know him, is associate professor at the Department of Radiology. Dr. Beache has a faculty member since 2006. But by the way, I already started my career here in 2006. So both of us started in the same year. He completed a radiology residency at Cleveland Clinic, an MRI postdoctor at Harvard General Hospital, and served as assistant professor at Johns Hopkins. And Dr. Beache, long time research has been developing functional and physiological method for heart analysis. So again, thank you, Dr. Beache, for accepting our invitation, and let us start.
So thank you once again. And so let me acknowledge, by the way, that a lot of the things that I will be talking about, especially the work done here, was in conjunction with students of Dr. El-Baz. So just emphasizing the importance of students in research, and in particular giving a plug for Dr. El-Baz's lab and the variety of things that go on there. All right. And so I'll be talking about cardiac biomechanics, because you all are engineers and computer scientists and so on, so that I will be describing the heart functioning in terms of engineering terms that you would be familiar with. Okay. And so the heart has many things that it does, but what we will be focusing on today is the contractile or the pump function, in which the heart delivers essentially blood and oxygen to various tissues of the body, whether it's the brain, whether it actually be the heart muscle itself, whether it be the kidney. So the brain is important, but if the heart didn't pump blood to the brain can't do its thing. All right? And so the ultimate goal of the heart function is to propel blood to the vascular beds. And so this is what I'll be talking about. All right. So there are conventional means of which one would use to analyze this heart function. So one classic means would be looking at the inner wall motion of the heart, and you are assessing that as an index of function to see how well it's working. And then there were some more advanced methods that we looked at, where you're not looking at the wall, the inner wall motion, but you're looking at the intrinsic contraction of the wall itself to index the function. And so this is a little bit finicky. So for instance, this is a cine or movie showing the walls of the heart, and so this is a ventricular wall here. This is the anterior wall of the ventricle. This is the inferior wall of the ventricle. But as you can see, there's a pumping function of the heart, and what you're seeing is the inner wall, the wall that's impinging on the cavity, shrinking in size as the heart contracts through the cardiac cycle, and that is one way of assessing function. But there's another more advanced way of assessing function, and now you see those squares, and I hope, so you see those squares on the heart wall, and what those squares are like, they're like a street grid. So you can localize points within the wall, just like you could tell someone meet you on 2 cross streets. Well, that's what that method is doing. And what you see is you can see the heart cavity changing size, so you could look at the inner wall function as before, but now you could look at the wall itself and assess the mechanics. Because if you look here on the chest wall, you notice those grid tags, like street grids, they're remaining square. So that what that is saying, like your chest wall isn't contracting, so there's no strain, there's no change in shape of the structure as the heart progresses through the cardiac cycle. But if you look on the heart wall itself, as the heart is beating, let's say this is a little bit finicky, as the heart is beating, those grids, they change from squares to triangles. And that is the basic analysis that we'll be doing. So strain is the fractional change in length. So you could imagine a tissue element, and as it strains, what happens is essentially squares get changed into triangles. And what I am geometrically representing are the principal axes as they deform with strain. Now, strain is mathematically a tensor, and for what that means, you have vectors and tensors and so on, so that it transforms like a tensor. And so that even though I'm showing you pictures and so on, there's the mathematics of tensors that is all behind that, okay? And then in terms of the representation, when you see, imagine if you have a square, but the axes are the same length. If it turns now into a triangle, it lengthens in one dimension and it shortens in the other. And that's exactly what happens to the wall of the heart. If you take a short axis image of the heart, when the heart, it contracts, it thickens in one dimension and it shortens in the other. So that geometrically, what is being represented by the tensors is actually what you see in terms of heart function. And just to digress a bit and tell you how serendipity works in this thing. Many years ago, when I was developing strain rate techniques with colleagues at Harvard, we had problems. How would you depict the two dimensions of shortening and lengthening, plus there's an angular dimension? And one day I was at my home and I was looking at a tile, and the tile had this sort of a ellipse shape, like American football, and it dawned on me that was what we needed to represent it. So sometimes, just out of serendipity, you come up with these things. But so just to say though, is that these tensors, because they have two magnitudes in a direction, you have to have a fancy means of depicting it. And so this cartoon shows, let's say you have a square, imagine a tissue element, and as it strains, right, that it lengthens in one dimension and it shortens, and so those depictions give you all the mathematical display of the tensors, right? Okay. All right. And another problem that we had with the tensors was that how do you take a complex object like that and then quote unquote quantify it, right? And so my background comes from physics, so what I thought that we would do then is to use invariants of a tensor, because for those of you who do these things in mathematics, that you know, the tensor has certain invariants, and one of them is a trace, and one of them is determinant, and then there's another third one with some mixed in components. But if you want to use a rigorous way of quantifying strains, then a reasonable way would be to use the invariants. Okay, so then that would not depend on what coordinate system that you use, that it would be the purest or most accurate representation. Okay. All right. So now, because we're talking of the heart and we're talking about function, I'm going to ground what we're talking about in terms of heart physiology. And so when you talk about heart physiology, this here, what it depicts on the top is these are pressure versus time loops, and that correspond pressure versus time loops, that it corresponds to ventricular volume changes. So like if you look at the heart during the cardiac cycle, if people are looking remotely, they may not be able to see as I point out about you or here. But for instance, if you look at the volumes as the heart progresses through the cardiac cycle, it has a flat phase, then it empties, then it fills rapidly, and then it has another flat phase. And so that very reproducible physiology is what I'm going to characterize with these function tools that we're using. And in particular, if one were to index strains through the cardiac cycle and simultaneously measure the pressure curves, that you see a similar thing where you have the pressure behaving as it should in classic cardiac physiology, and here the circumferential strains going through the cardiac cycle just like you would have if you have volume changes. Okay. So, many, many years ago, in order to make those kind of a strain or heart wall deformation measurements, they had to sew metallic sonographic type beads on the wall of a heart and then measure those changes. But with advances of MRI, we were able to essentially tag the heart with those black lines, and so without having to sew beads, we could localize points on the heart. And lo and behold now, in a non-invasive method using what they call radiofrequency tagging, so that those black lines that you saw on the heart, it's using the MR experiment to essentially create these almost physical type tags on the tissue that we could follow the deformation. So we're using MRI to use radiofrequency tagging to label those material points. And so this is an example here, starting from the top left and going all the way down across and going across and coming down, that you could see that the size of the heart cavity is changing, and then the tag grids, if you look carefully, you can see them bending as you progress through the cardiac cycle. That's one slice, and you're going through the heart cycle, and you could see the cavity is getting smaller and then it gets big again, but you could see that the tag grids are bending. And that's what we're measuring, that deformation, and we're measuring it at each point and getting the strain of the heart. By the way, I'm a very informal speaker, so if there's anyone who doesn't understand something or wants something amplified, you wouldn't throw me off guard if you ask a question, because if you ask a question, someone else in the audience might have a similar question. Okay, so our business is diagnosing disease. So you have to have then, from all this wonderful tag data, some sort of parameter to characterize what is normal versus what is abnormal. And so what we do is, if you average now the circumferential strain, and we're using now the mid-wall of the heart, and what you see then, if we then use some of the properties of the cardiac cycle and then fit that data in the top row, so we fit the circumferential strains, you see that a nice Fourier fitted curve that reproduces the ventricular function curve. So lo and behold, we're doing this crazy MR experiment, but we're getting out cardiac physiology just like the textbook. And in particular, from that curve, what we do is that we look at the peak emptying and the peak filling, and you see they're well-defined peaks. So we take the derivative of that curve, and there are those well-defined peaks that correspond to maximum emptying and maximum filling of the heart. So lo and behold, what we are doing now, we are saying we are separating the heart function into two phases, into the contractional emptying phase. You see, so this first part would be the contractional emptying phase, and then the second part would be the filling phase. And the emptying and the filling phases tell you different things. In fact, the filling phase is the more sensitive phase for detecting disease. And this curve I have below here, if there were any echocardiographers watching this at some point, they would recognize that as filling and emptying and filling they get from Doppler measurements. And so that peak emptying and peak filling are actually well-defined parameters that people use in other parts of heart disease. All right? And this is a very reproducible thing. If I were to take images of all of you all in the room, you would, if you are healthy, you would show some type of curve that looks like that. And if you are unhealthy in terms of your heart function, the slopes of the curve would actually show that. And so, for example, one other thing, from the strain curve, I take the derivative, and that's obviously the rate of strain, it's a derivative. However, there are MR techniques, which are techniques that I was involved with originally, where you use a different type of technique, where you sensitize the MRI to motion, and you can actually compute the strain rate directly. So you could get it from the strains and take the derivative, or you can actually acquire strain rates but directly, and you can display the data that it looks actually the same as the ones that I'm showing you. The only difference is, for those of you who think deeply about that, is that one approach is like a Eulerian approach to continuum mechanics, and the other one is like a Lagrangian approach. But it tells you the same thing. It's just like how you have calculus, you could have either the differential form or the integral form, but they tell you the same thing. Then that's essentially what that amounts to. And so, for instance, now just to show you that this is not all an empty exercise, let me talk about a disease example. So for something like hypertension, in hypertension, the wall of the heart, because of the increased pressure the heart is beating against, it's like if you are pumping your muscles, but the wall of the heart would hypertrophy or get thicker. Okay. The interesting thing, if you take one of the young football players in the UofL team, their heart, because of the exercise, actually, their heart muscle could be thick also. But there's a healthy thickness, obviously the athlete, and there's an unhealthy thickness, like in hypertension. So for instance, here we have curves, and I'm going to try to use the pointer again, hopefully it doesn't get finicky. So you have, okay, that didn't quite do. So you have four curves. One of them that you have, a normal, you have somebody with mild hypertrophy, and as the hypertrophy gets worse, if you look, as I said, in the filling part of the strain function curve, the mild hypertrophy, the slope looks like the normal, and as you get more and more hypertrophy, you could see that the slope is decreased. So that using these techniques, we can quantify the circumferential strain and actually show that the slopes or the strain rates are decreased in the filling phase of the cardiac cycle in disease versus healthy. Strikingly, it is not uncommon, the emptying phase, the slopes are not very different. And so that's what I was telling you, and that's something that has been known for some time, that techniques are more sensitive for diagnosing disease in the filling phase of the heart than the emptying phase of the heart. And so this is an example where we're showing this quantitatively to separate out people with hypertension and disease in the walls versus people who are healthy. Okay. In an example we did in Dr. Elbaz's lab, one of his students, Dr. Matt Nitskin, he did his PhD a couple years now, and he was helping me develop and analyze some methods for looking at these techniques in patients who had heart failure and were undergoing an experimental therapy with colleagues in cardiology here, and comparing what the strain function curves look like before treatment and after treatment. And so this is some real-life data from one patient where you see, let's look at the post-treatment, how you see the curve looks almost like a textbook now. So that post-treatment that you see, and again, if somebody's looking at it online, they wouldn't see what I'm pointing at, but you can see there's initial emptying phase, then it empties rapidly, then it fills rapidly, then there's a flat phase of the cardiac cycle, and then there's an additional phase where another ventricle kicks in, where another chamber kicks in. And so after this patient has been treated, there's almost a perfect textbook curve, but as you see before, that the function was abnormal. And so again, very, very powerful technique where you have patients where you could see a pre and post-treatment effect that you could detect using using this type of analysis. Okay, so I talked about looking at the average mid-wall strain, and that is good enough to diagnose many diseases. One can try to look at a pixel-by-pixel analysis and use a parametric representation where the strain at each pixel is represented by a false color. And so, again, with Dr. Matt Nitskin in Dr. El-Baz's lab, we developed such a color technique. The problem is that this type of data on a pixel-by-pixel basis can be somewhat noisy, and so one has to take with a grain of salt that kind of a picturization, that you have to probably have more robust imaging techniques to be able to analyze on that very fine basis. But if you use some smoothing techniques and so on, that you could perhaps distinguish differences in the inner wall versus the outer wall. But again, just to say that there are these pixel-by-pixel techniques where you actually map the functional data, the strain data, onto an anatomic image, so you're seeing both the anatomy and the function on a pixel-by-pixel basis. Okay, so quite apart from the MR techniques now using these fancy radiofrequency tagging, there is conventional, what we call Cine data, where that first image that I showed you, where you had the chamber, and I talked about endocardial, the inner wall motion and the cavity getting smaller. Well, that is called Cine imaging. You don't use any contrast agent, you don't use any fancy tagging, just conventional data. And so one of the things that we explored was, okay, there's all this Cine data that we have. Instead of just throwing it away and not using it to do this analysis, could we come up with a method to get tagged data from that, to get strain data from that conventional image? And so what we did was something called feature tracking, using feature analysis, things like the intensity of the tissue, the shape of the tissue, correlation among pixels, using statistical approaches such as the Markov-Gibbs random field method that was pioneered in Dr. El-Baz's lab, but using those techniques now to extract strain from conventional data. And so here's a schematic where we're using the features of the image to actually try to get out strain, so that you're using feature analysis to identify a point versus another point and compute that deformation. For those of you who may follow something called echocardiography, this corresponds to something called spectral tracking that they use with echocardiography, where again they use speckles and so on, features of the image, to compute strain. So in our hands, in Dr. El-Baz's lab, we combine the conventional Cine methods using feature tracking, and there you can see how we can get out circumferential strain and radial strain just like you can with the fancy MRI data. So we've actually doubled the utility of that conventional data to get out these advanced indices. And here, just showing that we could show that if you look at the strains, if you compared the inner wall to the outer wall, that the function on the inner wall is about almost 2 to 1 that of the outer wall, and that is a relationship that is well known. So that our method is sensitive enough that if you look across the wall of the heart, that you could see that the inner wall is contracting twice as hard as the outer wall. And similarly, if we look at inner, mid, and outer wall using the circumferential strains, we can see that like relationship. So that we've tested the validity of what we're doing to show that we're getting out these physiological relationships. And then showing here, plotting, for instance, the circumferential strain versus the ventricular volume, that you see those data, they actually overlap. Okay. All right. So we talked about cardiac function. We talked about these classic techniques, namely Cine, where you can get out things like the ventricular volume curve and things like emptying and filling. We talked about advanced imaging techniques using MRI. For instance, we're using something called radiofrequency tagging, where you label the myocardium with these grids, that you could get out advanced parameters such as strain. We talked about not using these fancy MRI acquisition techniques, but using the ordinary Cine data that people usually have, and using some feature tracking methods that we could get out these same strain read parameters. All right. Let's switch gears a little bit now and talk about analyzing the ventricular volume and trying to segment out that volume, and how that was done maybe classically, and how that is now approached in a newer fashion. So with the classic method, this is work taken from Dr. Fahmy Khalifa, who we worked and published with that again from Dr. El-Baz's lab, where on the top you see intensity measures, and down in the bottom you see spatial correlation between pictures, but we're using different predetermined features, whether, let's say intensity, shape, and correlation between pixels. So we are predetermining a finite amount of features and using that to extract essentially the inner contour of the heart, as we see in that last figure. And it is that inner contour that we're extracting that allows us to compute volumes. Okay? With the newer approaches, what you're doing, and because we have only presented this in abstract form and have not published, I'm going to try to not go too deeply into what we're doing, because obviously we haven't published that as yet. But what we're doing in a generic sense is we are, from the pixel data, we are getting a compact representation where you have an autoencoder determining what are the best features to use to analyze the data. So not unlike what you were talking about, what you were doing. So instead of, for instance, picking ahead of time 3 features, intensity, shape, correlation between pixels, you let the autoencoder decide what features it would use to extract that information. So that's sort of that's part of the deep learning process. And then the second part of it is then we use deep neural networks to then do an estimation of the parameter that we are interested in. So that again, it's a 2-step process, that we are no longer now predetermining a finitely small number of features, but this smart system is going to determine on its own, maybe look at 150 features and decide which one of those gives it the most efficient convergence. And so here is a schematic of what we're talking about, where we have trying to extract the inner contour of the cavity, and we have the autoencoder step, and then the deep neural network step, and then out of that pops out again that ubiquitous left ventricular volume curve, and that's what we're going to be using as our object in terms of goodness. And then with actual data that we've done, where we have the blue curve is the manual expert determination, and then the red curve is a large number of trials of that sort of deep learning self-defining method, and you see that there's very good agreement, and of course we've done statistics but to double check that. So that in a nutshell, and hopefully is giving you enough to stimulate thought and probably even some discussion in terms of the types of things that we are talking about doing, and that hopefully some of this would stimulate your interest to speak some more to Dr. El-Baz and some of his students and so on in terms of what they're doing. But again, these are some of the folks, Dr. Khalifa, Dr. Nitskin, they had graduated with their PhD about some years ago, and then some newer folks from Dr. El-Baz's lab that we're working on with some of these techniques. And Dr. El-Baz, is there anyone I failed to acknowledge on this that you might want to, because I never like to leave out any names of people who might be working. Yeah, so again, I thank you for your interest. I hope it was not too brief, that you couldn't get into some of the detail, but to get into some of the understanding, I'd be happy to speak offline, you know, with any of you after this, because I have some time, like to stick around. So thank you very much. And I hope you would all be doing something in deep learning or image analysis and so on in the near future. Thank you.